Thank you very much, madam. So next 25 minutes, I'm going to discuss about biochemical parameters in extremes of age. So in overview, introduction, biochemical parameters in preterm, newborn and children, and a little bit about pediatric reference intervals, and inborn errors of metabolism, and biochemical parameters in elderly and age-related specific problems. So introduction. So what do you mean by extremes of age? So that is preterm, newborn, children and elderly. So biochemical parameters in preterm, newborn and children I'm going to discuss first. And there are certain factors will influence of circulating analyte in this group, especially in newborn. That is because of the variation in the physical size, organ maturity, immune and hormonal responsiveness changes, nutrition and metabolism. So preterm, the definition is the baby with gestation of less than 37 completed weeks. So the important thing is the several organ systems mature between 34 and 37 weeks of gestation. There are certain specific problems related to this group, and one thing is renal immaturity. So renal immaturity together with low GFR leads to low creatinine clearance. So there are certain drugs which can have the prolonged half-life for renally excreted drugs, especially in preterm babies. When we are using those drugs, we to be very careful, especially drugs such as gentamicin. So either you have to use an alternative non-renally excreted drug or need close monitoring of these drug levels. Tubular leakness, particularly sodium, leads to high urinary sodium concentration and hyponatremia. So compared to hyponatremia is not that common, but it is common among premature babies. So especially in the first 2 to 3 days of life, and that is because of skin immaturity can lead to massive transudation of water and dehydration. So these babies develop increased weight loss, high urine osmolality, hypernatremia and increased serum osmolality. So this shows in y-axis the plasma sodium concentration and the x-axis the postnatal age. So you can see that initially there will be hypernatremia and then gradually comes down. So moving to albumin. So low albumin concentration and hypoproteinemia is due to decreased hepatic synthesis, and concentration now lower in preterm babies, and it is correlate with gestational age. So when the gestational age is lower, it is more prone to get low albumin levels. So about the physiological jaundice. 30 to 70% of healthy babies develop physiological jaundice after 48 hours of age. So usually this physiological jaundice total bilirubin concentration is less than 200 micromoles per liter with a peak at 3 to 4 days. Roughly this bilirubin levels falls to normal level in 7 to 10 days, and this is predominantly unconjugated bilirubin. And these children well and requires no investigations or treatment. So how we talk about the pathological jaundice? So jaundice, if it is appear unusually early within the first 24 hours, that is suggestive of hemolysis. And further, this physiological jaundice can also be exaggerated by dehydration, hypoxia, and preterm and in-birth traumas. High concentration of unconjugated bilirubin causes brain damage known as the Kernick terrors, which is especially seen in preterm babies. So, when to investigate a neonatal jaundice? Present at birth or appearing during the first 24 hours of life, and if it is persistent more than 2 weeks, days of life, and the total bilirubin concentration, if it is more than 250 micromoles per liter, and if it is conjugated hyperbilirubinemia, and when the jaundice is associated with other signs or symptoms of disease or sepsis, you need to investigate thoroughly. So, when we talk about the pathological jaundice, predominantly two components, that is unconjugated jaundice and related to conjugated jaundice, right? So, causes of conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia. So, unconjugated hyperbilirubinemia is basically due to increased hemolysis or decreased conjugation. So, increased hemolysis is common among children who are having rhesus or ABO incompatibility. And there are some red cell enzyme defects also, they also prone to get unconjugated hyperbilirubinemia. And there are certain disorders associated with decreased conjugation such as Crigler-Najjar syndrome and even hypothyroidism and breast milk jaundice. And there are causes of conjugated hyperbilirubinemia. It is one thing is maybe due to neonatal hepatitis. This neonatal hepatitis may be associated with TORCH, that is congenital infections. Or important thing is certain metabolic disorders such as inborn errors of metabolic disorders also get aggravated by causes jaundice, that is conjugated jaundice. And there are certain congenital abnormalities such as biliary atresia will also causes conjugated hyperbilirubinemia. So, if the child is having conjugated hyperbilirubinemia, that is alarming and need to be treated and find the cause is very much important. Then moving to calcium and phosphate disorders. So, the disorders are related to the problems associated with this age group is due to immature parathyroid hormone regulation, low albumin, poor intake and decreased responsiveness to vitamin D and increased calcitonin. One or few factors will contribute to this calcium and phosphate disturbances. So, in the fetal life, there is an active placental transport of calcium from the mother to the baby, especially in the third trimester. So, what will happen is the calcium concentration will be high. So, this is required for the mineralization of the fetal skeleton. So, this is basically controlled by parathyroid hormone related peptides. So, parathyroid hormone and vitamin D does not cross the placenta and limited role in fetal calcium homeostasis. What will happen at birth? The placental supply of calcium will be abruptly lost and neonate has to depend on the intestinal calcium intake and skeletal calcium stores to maintain a normal calcium level. So, serum calcium levels can fall physiologically after birth to lowest level at 24 to 48 hours. So, this is physiological drop of calcium. So, in term, it may be dropped up to 2 millimoles per liter. In premature, it is more pronounced, and 30 to 90% of patients will get hypocalcemia. Maybe the levels may be less than 1.75 millimoles per liter. And then what will happen is the plasma PTH concentration increases rapidly within first 2 days, and calcium levels slowly rise up to 2.2 to 2.6 millimoles per liter, which is causing normal calcium level. And you know that calcium has two forms, one is bound and the other one is free. So, the bound form, 80 to 90% of this bound form is bound to albumin. So, since these children are having reduced albumin concentration, total calcium concentration will be low. So, I think it is preferable to do albumin adjusted calcium, or either you have to do the ionized calcium, which is less affected. And as I have mentioned earlier, preterms are more affected. serum phosphate, which is high at birth. So the other analyte I'm going to discuss is alkaline phosphatase activity. Serum alkaline phosphatase activities, they are high, and that is one thing is placental alkaline phosphatase, which will keep for 3 to 4 days, and it will clear in 3 to 4 days time. And fetal intestinal alkaline phosphatase may comprise up to 50% of the total alkaline phosphatase in the first month of life. So when we compare it with the term and preterm babies, the preterm babies are having high alkaline phosphatase compared to the term babies. So it can be even up to 700 IU per liter in the absence of any pathology such as rickets. So when you are interpreting the alkaline phosphatase results, it has to be interpreted with pediatric reference intervals and according to the gestational age. Blood glucose. So these children, the newborns and preterms, are prone to hypoglycemia. So that is due to one thing is low glycogen stores and low intake. And fetus will receive continuous glucose supply via the placenta, and so fetal blood glucose reflect that of the mother. So what will happen is post-delivery, there will be a discontinuation of the nutrient supply, so the baby has to depend on the feed. So blood concentrations can fall abruptly, often as 1.7 millimoles per liter after birth, even in a healthy newborn. So hypoglycemia is corrected rapidly after feed. So blood glucose level is usual if it is more than 2.5 millimoles per liter by 12 hours of life. There are certain babies who are prone to develop hypoglycemia, such as preterm, low birth weight babies, especially babies born to diabetic mothers. And when the children are having these feeding problems, metabolic and endocrine disorders, certain disorders are also associated with hypoglycemia. So if the fatty acid oxidation generate the ketone bodies, which used for effectively by the brain as an energy supply. Serum cortisol. Peak cortisol is difficult to measure. So there are so many cross reactivities to the cortisol assay from the other steroid hormones, which causing high levels. And concentrations high at birth, which is maternal derived, and markedly fall after 24 hours. So I am going to give some brief description about some few important analytes, such as ferritin, low at birth, and TSH at birth will be high, rapid increase in 24 hours. So there has to be pediatric reference intervals in order to interpret the TSH. Free T4 high at birth and neonate. The other important parameter is the alpha fetoprotein, which is high at birth and levels falls in the first 2 weeks. So especially important to interpret with the pediatric reference interval, otherwise you think it is a pathological conditions. So ammonia preterms high concentration, even AST can go up to 120 in an early period less than 14 days. So what are the screening tests available in Sri Lanka? So only available screening test, newborn screening test in Sri Lanka is for congenital hypothyroidism. So what we do is we'll take a sample to a card known as Guthrie card, which is from a heel prick, and we analyze for TSH. But in other developed countries, they screen for treatable inborn errors of metabolism. It depends on the country to country. They use different disease screening tests. So the biochemical parameters in children, so I'm going to highlight few analytes. The total cholesterol, which is gradually increased from birth. Creatine kinase, high levels up to 4-fold in children. Creatinine is low, that is because of low muscle mass, increased to adult level after puberty. Ferritin high at 1 month, gradually falls lower concentration by 6 months. Potassium, you have to interpret according to the pediatric reference interval, up to 1 month it will be high. And protein is gradually increases from birth. Serum phosphate throughout childhood remains higher than the adult's concentration and rise at puberty, and levels come down to adult levels. So that is important to interpret according to the reference intervals. So what are the other important hormones in a childhood period? That is fertility hormone. So what are these fertility hormones? That is FSH, LH, prolactin and testosterone. So these hormones behave very complex pattern, and usually it is stable throughout the childhood, but if it will be increases in both sexes during the adolescent period. So in female adolescents, there will be changes, increase in estradiol, FSH, LH and progesterone, and testosterone increase in males, and sex hormone binding globulins decrease after puberty. And these hormone reference ranges have made according to the Tanner stage. So that is the pubertal stages. So there are wide partitions among these age and sex differences seen in this fertility hormone. So always this fertility hormones has to be interpreted with the Tanner age specific reference intervals. Urine test, as you all aware, that is the urine age and specific reference ranges are there. So when you are interpreting the urine test, maybe spot sample testing, so use age appropriate reference intervals. And for the creatinine clearance must be corrected for body surface area and increases with the growth. So it is very much important because it's not the adult reference ranges for the urine tests. So I'm not going to discuss much about the inborn errors of metabolism, but I'm just going to highlight few points. So what are these inborn errors of metabolism? So those are the disorders associated with amino acids, organic acid or carbohydrate metabolism or urea cycle disorders. These inborn errors of metabolisms are rare, right? But problem is these children or newborns are presented with similar clinical signs and symptoms. So it is more common, maybe developmental delay, epilepsy, learning difficulties. So it's very hard to find a probable cause depending on the signs and symptoms. So because of that, we need to screen them properly. If there is any delay for the diagnosis, leads to increased mortality as well as morbidity. So they will end up in lot of neurological issues. So sometimes we need to do genetic testing for the requirement as a genetic counseling for the parents. So what are the relevant biochemical tests? At least the relevant renal function, liver function, glucose level, total cholesterol, triglycerides, uric acid, creatine kinase, electrolyte, ammonia, lactate and urine ketone bodies. So relevant to your patient's clinical signs and symptoms. Suppose if the patient is having hypoglycemia, definitely you have to do the urine tests, the ketone bodies. And the other important thing is sometimes you will miss this precious time. So we have to at least collect and preserve appropriate samples. That is the important thing. So at least you need to take a spot urine sample, a serum sample and a EDTA sample for, then you can, the clinicians can discuss with the relevant laboratory in order to what are the tests you are going to perform. Suppose if the patient is having hypoglycemia, if you treat with glucose, so then you take afterwards, so there is no point taking, sometimes it will not be positive. So, because since I have discussed regarding this always the reference intervals, so the pediatric reference intervals, there is a wide variation of intervals available, but there is a one study performed in Canadian Laboratory Initiative on Pediatric Reference Interval, which is established for using few analyzers, and it is for selected biochemical markers, protein markers, lipid and enzyme and endocrine markers. So, use of pre-existing adult reference intervals for children are inappropriate, but I think it is the practice. So, need to establish the pediatric specific reference interval, but even with that, there are huge gaps to develop this pediatric reference interval, because one thing is we need large number of partitions depending on the age, and it is very difficult to obtain blood samples even from healthy children and neonates, and lack of robust data resulting from small sample sizes. So it's not an easy task, but it's better to have a pediatric reference interval. So who are the elderly people? I'm not going to discuss about the definitions. Different guidelines give different definitions. So usually for the adult reference interval, we use 20 to 40 years of age. So laboratory reports in elderly may be deviating from the normal reference interval sometimes. Why? There are certain factors associated with that, because organ function will reduce with the age and it not be apparent in healthy, right? And other thing is decreased reserve capacity may be apparent with mild diseases. So what are the physiological changes associated with elderly? So the gonadal hormones will be decreasing, bone loss, renal function impairment, and blood fat levels will be high. So what are the lifestyle modifications? As you all aware, they are very inactive, and muscle mass is decreasing, and less supply of vitamin D due to less exposure to sunlight. So they are hardly going outside. So obviously their vitamin D level will be low. And dietary factors, there are a lot of problems associated with digestion and absorption. There are dental abnormalities, and so there will be vitamin and mineral trace deficiencies, and some they are having problem with alcoholism and obesity. And most of these elderly are on medicinal therapy, drugs, and dietary supplements, which also will affect the test results. So these are the some analytes will be increasing, and some analytes will be decreasing, especially alkaline phosphatase, FSH, LH will be increased, cholesterol and TG will be increased, and especially vitamin D will be low, and CK, estradiol, testosterone, total calcium will be low. So they are having increased blood glucose level. So blood glucose concentration increase proportional to the age, because the glucose tolerance is increasing due to insulin resistance. So it is observed up to 25% of patients of elderly above the age of 75 years. So what will happen to iron levels? It will be decreasing. So that is due to one thing is impaired production of gastric juice, which contains hydrochloric acid, facilitate the conversion of ferric form to ferrous with need for the absorption, and iron stores also get decreased because of this issue. And cholesterol and triglycerides will be high, and total cholesterol level increase by 1 millimoles per liter above the 60 years of age, and triglycerides can be increased up to 30 to 50% in males and females respectively, and HDL will be vary with the sex. So when you are interpreting, it is important to interpret with the age. So what will happen to renal function? So normal renal function actually, because of decreased nephrons, decreased by 30 to 45%. And this is accompanied by the decrease of GFR. But what will happen to creatine levels? Because the body mass become decreased and creatine levels hardly changing. And despite fall in GFR, renal function is sufficient for normal day-to-day homeostasis functions. So albumin level low, that is because of the synthesis decrease, and because of that albumin binding analytes such as total calcium will be low. What about the fluid balance? They are more prone to get fluid and electrolyte imbalances. That is because of renal response to vasopressin, third sensation, and aldosterone response to renin will be reduced with the age. Thyroid function, that is other important thing, they shows the signs and symptoms of hypothyroidism, weakness, slowness and tiredness. So these patients, among these elderly population, non-thyroid illnesses are common. So what are the non-thyroid illnesses? That is the illnesses other than the thyroid disorder. So we have to interpret thyroid function test very cautiously. So the screen test is TSH, and there are a lot of medications used by old people will affect the TSH. For an example, glucocorticoid hormone suppress TSH, lithium inhibit thyroxine secretion which causes hypothyroidism, amiodarone, the drug which is used for cardiac arrhythmias, can causes either hypo or hyperthyroidism depending on the patient. So we are in trouble. What should be done, right? So decide whether the laboratory test results is deviate from healthy reference range. Think twice whether that is a physiology or a pathology. Anyway, it's not clear-cut answer, it will be really hard. So because of that, for elderly population, it should be never establish a diagnosis depending exclusively on the laboratory test results. It has to be interpreted with the clinical history and examination findings. And establishment of old age specific reference interval, it's not easy task. Why? Most of this elderly population, they are having certain disorders, and there are a lot of the population, they are on drugs. So it is very hard to find normal, as you call normal elderly population. I didn't find any reference range established for old age. So what are the screen tests available for elderly? So you can check for potassium levels. Especially if the patients are on diuretics, they are prone to get hypokalemia, and when they are on potassium sparing diuretics, they are prone to get hyperkalemia. And when there is a renal impairment, do serum creatinine, and serum calcium, it's more prone to get hypocalcemia due to osteomalacia, and hypercalcemia also be reported due to hyperparathyroidism. ALP is a good screening one, that is to find out osteomalacia, Paget's disease, it's not common much in Sri Lanka, and malignancy. So the glucose also be done to exclude diabetes mellitus. And TSH and T4, it's multiple causes, maybe nutritional factors, chronic illnesses and medications. So patient can have hypothyroidism, hyperthyroidism or non-thyroid illnesses. Yeah, that's all. So regarding this patient, so the take-home message is it's important to interpret these results with the especially for pediatric population, the age-specific reference ranges. I don't think in most of our hospital laboratories we give pediatric reference interval. So I think it is done in, especially in Late Regio Hospital and Sirma Bandarnayaka, which are specialized children's hospitals. But so the clinicians, sometimes they are in trouble because they also don't know. So what I advise is to, if they ask from me, use the caliper reference ranges. But even with that, caliber study is actually, it is, they have done for few analyzers. So I can't give the analyzer name, so for few analyzers. So because of that, it's also not very practical. So, and it's better if you can have our own pediatric reference intervals in our laboratories, which is a hard task. Thank you.